Thanks for that, John Howard. We next are bringing forth Michael Hodgson, the Chief Medical Officer from the Occupational Safety and Health Administration, Department of Labor. Welcome.
Thanks, Dr. Goldman and Dr. Laurie for the invitation to present some views here that come out of the Occupational Safety and Health Administration. The meeting comes obviously at a very timely and opportune time, but it reflects, to our surprise, a failure of planning. The comprehensive emergency management cycle of mitigation, preparedness, response, and recovery implies that here in the middle of response, we've done adequate preparedness and mitigation, and that doesn't appear to be the case. So we wonder whether there's some lesson on thinking through how we approach this, given the lessons from the August 99 meeting on biological agents with D.A. Henderson and Dr. Lederberg, the SARS and H1N1 pandemic. There may be some lessons on thinking about the overlap between occupational health and infectious disease and failing to think through the reality of work in the real world. In that context, it's worth remembering the lessons from Sharp's injury prevention, involving healthcare workers early on in the reality testing of intervention strategies has proven important in some things like safer needles and devices with engineered Sharp's injury prevention. We didn't do that here, as we'll get to in a minute. So let me think with you about some problems for hospitals and for some problems outside of hospitals. Over the last 12 years, Médecins Sans Frontières has managed Ebola outbreaks successfully in many countries with very specific guidance on the web. Some of that guidance was incorporated into WHO lessons. Some of the other lessons weren't disseminated as effectively as they might have been. So the training methods, for example, doffing with observers, the buddy system, the emphasis on immediate cleaning and removal of vomit and diarrhea, and the implications of Ebola treatment unit design, how to manage flow in the real world, is an issue. Although most hospitals now have a plan, a few weeks late, it turns out that many of those hospitals are still struggling not just with the process flow, but the real infrastructure. So many hospitals right now are doing construction to replace walls, to figure out how to manage airflow and how to have enough space to stage doffing with a buddy without contaminating the buddy, the worker who's doffing equipment, or the rest of the room in which they're moving around. So how much space is needed in reality? How much training is really needed to doff safely? There are a number of courses out there. UCLA just looked at how effective doffing training with 16 hours over 10 days would be, and fewer than 1/3 of their staff were actually able to pass their internal test. That suggests that doffing training is pretty hard, and if you remember the MSF focus on doffing and buddy observation, the question of why two physicians who came back self-contaminated and became ill isn't so surprising. If you're not used to doing something regularly and energetically, it's just not going to work that well. What are effective ways and competing strategies to manage waste in a modern hospital? So everybody's heard about the Ebola, the management strategy at Emory with an autoclaving unit on the ward. Many hospitals don't have a large autoclave. They don't have portable autoclaves. And so the question of how to move that waste around has generated new discussions between agencies that hadn't been involved. Dr. Leduc pointed out some of the borderline ludicrous problems that have arisen, but these are all failure of preparedness and thinking through up front how to manage something. What are just-in-time management strategies for hospitals? Should the nurse at the triage desk call an infectious disease consult or initiate the hospital incident command system? This is emergency management stuff, and most hospitals hadn't thought that through. Is there a lesson for us? Given the effectiveness of the MSF approach to infection control, where is the boundary between appropriate use of surgical masks and respirators? The CDC has, meanwhile, put N95s and PAPRs up, but in fact, PAPRs come in different strategies. There are PAPRs with a protection factor of 25. There are PAPRs with protection factors of 1,000. The latter were those that were identified as necessary in the work around sarin-contaminated patients, and many hospitals had actually purchased those. What is, in fact, needed for appropriate protection? And then, finally, in hospitals, what is the perspective of frontline healthcare workers on managing the infrastructure? It turns out, if you read MSF documents, the non-hierarchical team approach to healthcare worker protection and leadership commitment are likely essential. How do we as a system get to involving healthcare workers early into that process? And then thinking through some problems outside of the hospital, where all does the virus migrate as we think through use and destruction? So as we think through the critical infrastructure and key resource sectors, where all are there processes or where could engineering failures generate exposure? Plumbers in hospitals are a widely discussed phenomenon. You know, when they fix leaks, is that a hazard? How do airplane cleaners clean toilets in the airplanes? How do truck drivers transporting waste deal with accidents? So thinking those through in a comprehensive approach is essential. What kinds of PPE are necessary in each one of those processes? And then what do we know about the levels of PPE necessary for each of those? Finally, based on all of this, what do we think, how can we better define ways that the public health system communicate these risks to workers in ways that they understand those and act appropriately? Do we remember the lessons from SARS and Toronto? If we haven't invested the working people who run the risk in developing the protection strategies, in fact, they won't come to work. That was one of the big Toronto lessons. And so how do we create a safety culture that makes people feel comfortable and lets them come to work? Thanks.